Good afternoon, ladies and gentlemen. Next, I would like to talk on a very important topic called management of severe hypertension in pregnancy and in the postpartum period. Ladies and gentlemen, I've got no conflict of interest in this talk. Now, I believe this topic is timely. In the last 2 years, there's been numerous recent updates about management of severe hypertension, namely the ACOG guidelines on management of hypertensive emergencies, the WHO recommendations, and the ACOG Safe Motherhood Initiative, all of which highlighting the importance and updates of management of patients with severe hypertension. So with that in mind, ladies and gentlemen, I'm going to talk about the significance of severe hypertension. What is the difference between severe hypertension and hypertensive emergencies? Is oral route just as effective as the parenteral route? What should be our first line? What should be our second line? When should we start magnesium sulfate? When should we give obstetrician's favorite medication called corticosteroids? And when should we deliver? All of which I shall try to cover the next 25 minutes. So ladies and gentlemen, let's first take a look at the EMBRACE report. Now, based on the most recent EMBRACE report, they're doing extremely well in the UK, and pre-eclampsia is the 11th cause of maternal deaths in the UK. But let's come back to these parts of the world and in Malaysia, ladies and gentlemen. Now, the leading cause of maternal death for many years remains medical disorders in pregnancy, which it was a respiratory cause, and then it was a cardiac cause, and pulmonary embolism still remains a significant cause, and deaths from PPH remains high. However, ladies and gentlemen, I would like to bring your attention to hypertensive disorders in pregnancy. It remains a significant cause. It is not the 11th cause, it is the 4th cause of maternal deaths in Malaysia. So in these parts of the world, mothers dying from hypertensive disorders in pregnancy remains significantly high. We should be better. We should be able to diagnose. We should manage them better to reduce these deaths in the next few years. So ladies and gentlemen, what's the difference between severe hypertension and hypertensive emergencies? Unlike pre-eclampsia, where there is a definition which includes symptoms, a definition which includes an organ damage, the diagnosis of severe or hypertension emergencies involves two numbers: a systolic blood pressure of above 160, a diastolic blood pressure of above 110. Now, in an acute setting, that becomes a hypertensive emergency, and that is what we should all be calling. And it's ideal to treat these patients within 15 minutes. However, the mother remains elevatedly high, the blood pressure remains high for beyond 4 hours, and then you can then classify the mother as having severe hypertension. So first, hypertensive emergency, if that remains high for a period of beyond 4 hours, that is known as severe hypertension. Now, I would like to bring your attention to this wonderful trial called the CHIPS trial. The CHIPS trial was published a few years ago, looking into the effectiveness of tight control versus less tight control with regards to management of hypertension in pregnancy. Although it showed no significant difference whether you have a tight control or less tight control, if you control them tightly, the incidence of severe hypertension is far less. And this is one of the reasons why I believe, for one, it's important to have a tight control of hypertension in pregnancy, because it significantly reduces the incidence of severe hypertension, although there's no difference statistically with regards to maternal or fetal outcomes. So ladies and gentlemen, when should you treat? I believe the golden minute is 15 minutes. Now, this does not mean that you should wait for 15 minutes before you treat the mother. What it purely highlights is that it should be a hypertensive emergency. You should treat it as soon as possible to reduce maternal complications. Now, what are the goals of treatment? I believe there are 3 goals of treatment. Goal number 1 is not to normalize the blood pressure. It is purely to reduce the level of systolic blood pressure and diastolic blood pressure to a non-severe level. And finally, it's important to avoid underperfusion of the fetal placental unit, because that later might have fetal implications. So ladies and gentlemen, what is the first line? Now, for many years, we thought that parenteral route was far more superior than the oral route, until this wonderful paper which showed that oral nifedipine is just as good and as effective as the parenteral route. So the first line, ladies and gentlemen, should be oral nifedipine. This can be followed by a parenteral route, either IV Levator or IV hydrolyzing. But what can you give first? Now, based on various studies, IV Levator should be the first parenteral route as compared to IV hydrolyzing, because that is associated with less fetal heart rate abnormalities, and that is associated with less maternal complications, because IV hydrolyzing is a potent vasodilator. It may cause more fetal heart rate abnormalities. Unless the patient has got contraindications for Levator, then you can use hydrolyzing. Now, ladies and gentlemen, let's relook the evidence for oral nifedipine, comparing its efficacy against parenteral antihypertensives. So this wonderful study showed that if you use oral nifedipine, the incidence of persistent hypertension is low, the incidence of morbidity is unchanged, the incidence of hypotension is low. However, the incidence of maternal side effects are moderately high. With regards to fetal outcome, if you use oral nifedipine, the incidence of fetal heart rate abnormalities is low. However, the incidence of intrauterine death and low ABGA scores are high. So such patients, you do need to monitor the mother, you do need to monitor the baby as well, namely because the incidence of neonatal and intrauterine deaths are high. So ladies and gentlemen, what is then the algorithm for management of patients with oral nifedipine? I believe the moment you diagnose a hypertensive emergency, it is okay to give an immediate release of nifedipine, not sublingually, but orally 10 milligrams. Monitor the mother for side effects, monitor the baby for fetal heart rate abnormalities, repeat the blood pressure 20 minutes later. If that remains elevated, it is okay to give 20 milligrams of immediate release nifedipine now, but it's important to continue to monitor the mother. After 10 milligrams, after 20 milligrams, the blood pressure remains high, you can give another 20 milligrams, by of which is already been 1 hour. But please remember that mother and that baby needs to be monitored. However, after 60 minutes, if the blood pressure remains high, it is time to consider parenteral route. The recommendation is IV Levator, ladies and gentlemen. So the first line is oral nifedipine, but you need to make a decision to treat within 15 minutes. Within 1 hour, if there's no response, you need to convert to a parenteral route. Now, what is the algorithm for IV Levator? So the recommendation, what do you choose first? As mentioned earlier, should be IV Levator first, unless there are contraindications, and IV hydrolyzing second, because of the increase in incidence of fetal heart rate abnormalities via hydrolyzing use. So the recommendation is to give 20 milligrams infusion over 2 minutes. Repeat the blood pressure in 10 minutes time, monitor the mother and the baby. Within 10 minutes, if there are no response, is to give 40 milligrams of IV Levator and continue to monitor the mother and the baby. You have given 20, you have given 40 milligrams, the blood pressure remains high, it is okay to give 80 milligrams of IV Levator. So ladies and gentlemen, if after giving 80 milligrams of IV Levator, the blood pressure remains high, it is time to consider IV hydrolysis. I would like to highlight one important fact based on my own experience. A significant number of Asians are actually Levator resistant, ladies and gentlemen. So do think of Levator resistance, especially if the blood pressure does not drop. It has been 30 minutes and you have given 20 milligrams, 40 milligrams, and 80 milligrams. The blood pressure remains high. It is okay to give IV hydrolyzing. But please remember, it is important to continuously monitor the mother and the baby. Now, what is the protocol for IV hydrolyzing? So IV hydrolyzing is your second choice of parenteral route. The recommendation is to give 5 or 10 milligrams over 2 to 5 minutes. You don't really need to hydrate the mother before IV hydrolyzing. It's okay to give a slow bolus over 2 to 5 minutes. If the blood pressure remains high, after 20 minutes, you can then give 10 milligrams of hydrolyzing over 2 minutes. Continue to monitor the mother and the baby. And after 5 milligrams, after 10 milligrams, the blood pressure remains high. It is time now to consider IV Levator, ladies and gentlemen. Now, all the 3 algorithms which I mentioned, oral nifedipine, IV Levator, and IV hydrolyzing, all these studies purely talk about bolus alone. It does not talk about combination of therapies. It does not talk about the impact of bolus plus infusion. But these are some of the options that you may consider in your own clinical practice. So, ladies and gentlemen, I, for one, believe that it should be an individualized approach. Assess what is the patient's trend of escalation of antihypertensive. Review the effectiveness of combination of antihypertensives, perhaps IV Levator plus oral nifedipine, or IV hydrolyzing plus oral nifedipine. It works wonderful in combination. Perhaps it is not just a bolus dose, but a bolus plus infusion is far more superior than a bolus dose alone. And that is even more individualized and more precise, because you'll be able to titrate it up accordingly based on the mother's observations. It's so important to consider the gestation. The mother's very early in the pregnancy, early in the 2nd or 3rd trimester. Perhaps continuing the pregnancy is far more beneficial for fetal reasons. But if the mother's near term of the mother is past 34 weeks, perhaps there's limited role in prolonging the pregnancy. Apart from treating the number, it is also important to assess the mother's symptoms. It's also important to assess presence of end organ damage. And please do not forget the fetus. You should assess the fetus with regards to amniotic fluid index, Dopplers, fetal growth, and fetal size. And having all this information, you can now holistically manage the patient who has got severe hypertension. So, ladies and gentlemen, having stabilized the mother, having given her first line of medications, what are your second line of medications? I would like to bring your attention to this Lancet paper, which looked into 3 commonly used medications, which is extended release nifedipine, Levator, and methyldopa. Now, interestingly, this paper showed that all 3 of these medications are just as effective in managing hypertension, but the use of nifedipine is associated with a better blood pressure control in achieving the primary aim of controlling severe hypertension. So all 3 are safe, all 3 are effective, but the use of slow release nifedipine has been proven to be superior as compared to the use of Levator and methyldopa. What is important is to appreciate the maximum dose of these medications. The use of slow release nifedipine, your maximum dose should be 120 milligrams per day. You can use 30 milligrams daily, go up to 30 milligrams BD. You can go up to 30 milligrams TDS, but the maximum dose is 120 milligrams. The maximum recommended dose of Levator is 2,400 milligrams per day in divided doses. The maximum dose of methyldopa is 3,000 milligrams in 3 divided doses. So, ladies and gentlemen, I believe, just as what I've highlighted earlier on the importance of an individualized care, it is important to involve a senior personnel in the management of a patient. And what is the importance and the benefits of involving a consultant? I believe we have to weigh the benefits of managing the mother as compared to the benefits of prolonging the pregnancy, because that decision I, for one, find extremely difficult. So management of hypertension is not just about control of blood pressure, but at one moment of time, you will have to consider delivery for maternal or fetal indications. Now, let's move on to the next topic. Do we now really need to deliver all mothers who presented with severe hypertension? I'd like to bring your attention to this wonderful paper which was published in the BJOC in the recent few months. It looked into the effects of pregnancy prolongation in patients with early onset preeclampsia and to look whether there are any fetal harm or maternal harm. And interestingly, ladies and gentlemen, they divided the patients who presented with severe preeclampsia, which I think can be extrapolated to our cohort of severe hypertension. They looked into 3 groups. If you deliver them within 6 days, if you deliver them between 7 to 13 days, if you deliver them after 14 days, is there any fetal harm? Now, interestingly, if you prolong the pregnancy for a period of average of 14 days, there's no increase in the incidence of stillbirths, there's no increase in incidence of infant mortality, there's no increase in incidence of abruption, but there has been some fetal benefits. So ladies and gentlemen, it is okay to prolong a pregnancy for a period of 14 days, at least the patient presented with severe preeclampsia and has got no significant fetal harm. How about maternal harm? Can you prolong the pregnancy for at least a period of 14 days, or does that cause maternal harm? So let's go back to the same paper. They divided the cohort into 3 groups, and they realized if you prolong the pregnancy for a minimum period of 14 days, there's no increase in incidence of metabolic syndrome, there's no increase in incidence of cardiac disease, there's no increase in implications to the renal disease, and it is safe to prolong the pregnancy up to an average of 14 days. So ladies and gentlemen, based on this study, I believe you do not really need to deliver the mother soon following an hypertensive emergency or following a diagnosis of severe hypertension. It is okay, perhaps reasonable, to prolong the pregnancy with a mean average of 14 days, and this does not cause any harm to the fetus or harm to the mother, depending on the clinical circumstances. Let's talk about steroids. Now, when should we give steroids? When should we not give steroids? I, for one, ladies and gentlemen, find that the single most medication which is abused by all obstetricians is steroids. So I believe the steroids is like a silver bullet. You should shoot it once, but you should shoot it timely, and you should only administer if you are very sure that you're going to deliver the mother between the next 3 to 48 hours. If you are not sure, please do not shoot the silver bullet prematurely. Why is that so? I'd like to highlight the outcomes of the MAC trial, which followed up babies who were given multiple courses of corticosteroids for preterm deliveries and followed them up to the age of 5. Now, based on the MAC trial, although they showed there's no increase or decrease in the incidence of death or disability up to the age of 5, I believe we should not abuse steroids and we should try to reduce the need for repeated antenatal corticosteroids. Now, why is that so? I would like to highlight this wonderful meta-analysis that showed that in patients that were given repeated doses of steroids, especially if it is given beyond 3 times, or especially in fetuses who were given a cumulative dose of above 48 milligrams, there was a significant impairment, not in death, not in disability, but in fetal growth. So ladies and gentlemen, use steroids timely. You may not always get the timing right, but use it if you think you're going to deliver the mother within the next 48 hours. It is a single bullet, use it wisely. Now, when should you give magnesium sulfate? I believe there are 4 indications for magnesium sulfate. Number 1, if the patient has got eclampsia. Number 2, for fetal neuroprotection. And number 3, for prevention of preeclampsia. And number 4, you may also use magnesium sulfate if the patient has got an acute exacerbation of bronchial asthma. Now, the use of magnesium sulfate for prophylaxis of eclampsia is controversial. Following the MAGPIE trial, I think everyone has started giving everyone magnesium sulfate, but I believe we should appreciate the studies following the post-MAGPIE trial. The post-MAGPIE trial showed that in countries where the incidence of eclampsia is low, in developed countries where they have facilities to monitor the mother and the baby, the benefits and the number of patients that needed to be treated with magnesium sulfate is extremely high. So ladies and gentlemen, I believe not all patients on severe hypertension needs magnesium sulfate unless the patient has got benefits of neuroprotection, unless the patient is symptomatic, or unless the patient has got eclampsia. I think we should not routinely give it for all patients with severe preeclampsia. Now, what is the dosage of magnesium sulfate? I think we can extrapolate best evidence from the collaborative eclampsia trial, which is 2 grams bolus over 1 hour, followed by 1 gram an hour. Now, the duration of magnesium sulfate remains controversial, but traditionally people will give it for 24 hours from eclampsia or 24 hours after delivery, whichever comes later. So just like corticosteroids, there's been an FDA concern with regards to prolonged use of magnesium sulfate that is associated with fetal skeletal dysplasia, skeletal bone issues, reduction in bone quality. So ladies and gentlemen, just like corticosteroids, I think you should give magnesium sulfate if you think delivery is imminent, average in the next 4 to 24 hours. But please try to avoid as best as possible repeated doses of magnesium sulfate or prolonged use of magnesium sulfate. So finally, if the patient is on magnesium sulfate, what is the preferred parenteral route? Should you give IV Levator or should you give IV hydrolyzing? There was a time in the past where patients on magnesium sulfate, we avoided IV hydrolyzing, but that is no longer true, ladies and gentlemen. You can use both options. You can choose Levator as the first line, but if the patient has got contraindications or Levator resistance, it's okay to use a combination of IV hydrolyzing and IV magnesium sulfate that does not cause significant maternal or fetal harm. So, what are the interventions worth reflecting? I think it should not just be a number. I think we need to have a more holistic definition. What is the symptoms? What is the gestation? What is the trend of escalation of antihypertensive? Is there end organ damage? Take all of this into consideration before you manage a patient. We should stop using serum uric acid, ladies and gentlemen. It has got no implications of severity. It is not a prognostic tool. Although split-PLGF ratio has been implicated in the management of severe hypertension or preeclampsia, you can use it to negate preeclampsia, but it is not recommended to be used to guide management of patients with severe hypertension. If your split-PLGF ratio is low, the patient does not have preeclampsia, but if it's high, it does not mean anything else and should not be used to guide management. We should also perhaps move away from 24 hours urine protein. The recommendation now is to do a spot urine protein-creatinine ratio. You should be able to quantify the protein immediately. And we should not abuse steroids, not abuse magnesium sulfate, and not all patients with hypertensive emergencies, you should subject them to an urgent cesarean section. Please remember, you have got an average of 14 days. So ladies and gentlemen, having covered antenatal and intrapartum hypertension, I would like to talk about postpartum hypertension. I would like to bring your attention to this wonderful paper in the TOG talking about postpartum hypertension. I think it is important that you risk stratify patients about who are high risk for postpartum hypertension. Gone are the days where we keep such mothers 5 days in the ward, check daily albumins. I think it's an ancient practice. Now you should risk stratify them into high risk of postpartum hypertension and treat them, or low risk for postpartum hypertension, discharge them and follow them up closely. So mothers who are high risk for postpartum hypertension are mothers who are delivered preterm, mothers who required numerous antihypertensive therapies in the antenatal period, mothers with severe hypertension, or mothers who had antenatal preeclampsia. These 4 cohort of patients are high risk for postpartum hypertension. It's important not to reduce the dose. It is important not to stop their medications, but to continue the antihypertensive medications throughout the postpartum period, especially if you think they are high risk of postpartum hypertension. Now, the postpartum period is a different period as compared to the antenatal period, and various medications are safe. It is not just Levator, it's not just nifedipine, ACE inhibitors are safe, enalapril is safe, captopril are safe, and evidence continues to evolve about safety of numerous medications which are not contraindicated in the breastfeeding period. So ladies and gentlemen, the take-home message for postpartum hypertension: do not stop medications, do not reduce medications, risk stratify patients into high risk and low risk. It is okay to use ACE inhibitors and newer antihypertensive medications because breastfeeding is not contraindicated. So to summarize, ladies and gentlemen, all patients are considered hypertensive emergency. Their systolic blood pressure is above 160. Their diastolic blood pressure is above 110, not 100 milligrams. Now, oral nifedipine can be used as a first line. It is just as effective as the parenteral route, especially if you are in the primary care setting, if you are in the emergency department, if you are to transfer the patient to a tertiary center. But please remember, the maternal side effects are significant. It is associated with fetal heart rate abnormalities. You need to monitor the mother and the baby. Parenteral can be used as a second line, but you should administer within 1 hour. The preferred parenteral route is IV Levator unless there are contraindications. You can give bolus followed by infusion. The recommendation is 20 milligrams Levator, 40 milligrams Levator, and 80 milligrams of Levator. In my own setting, I prefer to use the parenteral route first because the nurse is then empowered to titrate it upwards or downwards, and compared to someone who needs to monitor the patient closely and make a decision for second line nifedipine and a third line nifedipine. After management of severe hypertension, it's important to involve a consultant, and this patient should ideally be monitored in the high dependency ward, ideally using an early obstetric warning scoring system because the maternal and fetal implications are significant. Please monitor the mother, look out for acute pulmonary edema. So you need to monitor respiratory rate, you need to monitor pulse oximetry. Look for complications, abruption, and intraventricular hemorrhage. Ladies and gentlemen, it's not just severe hypertension, but if the mother has got an end organ damage, then you need to revisit the diagnosis and perhaps ensure this is not pre-eclampsia. Please do not abuse steroids for mothers with severe hypertension. Please do not abuse magnesium sulfate. Only give them if you think you're going to deliver them in the next 24 hours. I believe hypertension emergencies of severe hypertension, there is an urgency to treat, but there's actually no urgency to deliver. The goal and aim is to control the blood pressure and then stabilize the mother, await time, and decide an optimal timing of delivery. But the mother and the baby has to be monitored till then. So ladies and gentlemen, if you do need more resources, I would strongly encourage you to visit the Malaysian Obstetric Medicine website known as www.obstetricmedicine.my. It is filled with all the resources that you need with regards to obstetric medicine. And with that, I would like to thank you all for your attention, and do visit our website if you do have more queries. Thank you.